Good afternoon or good morning to everyone. Welcome to the DNPAO seminar series, From Hospital to Community, Monitoring, Promoting, and Supporting Breastfeeding. Welcome to our webinar for today. We have an exciting opportunity today, and we'll be offering this in English and Spanish. Hi, everybody. I'm Janelle Gunn. Welcome to our DNPAO seminar series. We have an excellent seminar today on breastfeeding and are so glad that you have joined us to hear this great information and stories from the field. As a reminder, this seminar is being recorded. It'll be offered later on the DNPAO website. If you've missed some past seminars and are interested in them, you can find those on our website. All of your lines are muted, but we launch your questions and answers. We'll have some time at the end for that. And so please go ahead and submit them whenever they come to you, and we will try to get to as many as we can during the time we have allotted today. We have a truly outstanding set of speakers for you today. I think you're going to really enjoy the information. First, we have Lieutenant Kristin Marks. She's with us here at CDC in the Division of Nutrition, Physical Activity, and Obesity. She's a scientist officer for the United States Public Health Service, and she's an epidemiologist on our maternal, infant, and toddler nutrition team. Next, we have Daurice Grossniklaus, and she's a health scientist also with us here at CDC, and she works to improve maternity care practices supportive of breastfeeding. Then we'll have Harumi Reis-Reilly. She's a lead program analyst at the National Association of County and City Health Officials, otherwise known as NACCHO. She's a public health professional, nutritionist, and international board certified lactation consultant. She will be followed by Paulina Irsis. We have a special guest from doing some work in Colorado, and she will also be joined by Lucy Guerreca, who will be sharing some of her experiences and work in the Colorado area as well. All right, our agenda for today is to review the maternity practices in infant nutrition and care survey, also called mPINC. Our work covering supporting the U.S. hospitals to provide safe, evidence-based maternity care supportive of breastfeeding. Then we will hear an overview of NACCHO's work to advance continuity of care in communities across the United States. And then we'll hear from Cuenta Conmigo, cooperative successful efforts to advance continuity of care in Colorado. So let's go ahead and get started. I'm going to hand it over to my colleague, Lieutenant Marks. Kristin?
Good afternoon. Thank you for the opportunity to share our team's work on maternity practices in infant nutrition and care. Breastfeeding initiation rates have increased over the past 2 decades. This considerable increase from 70 to 83% is due in part to improved maternity care practices. In the United States, nearly all infants are born in a hospital. Maternity care practices in hospitals in the first hours and days after birth make a difference in whether and how long infants are breastfed. Hospitals have an important influence on how infants are fed, as there are several key supportive hospital practices that can improve breastfeeding outcomes. Maternity care practices make a difference in breastfeeding. So what is CDC doing to monitor these practices? CDC's National Survey of Maternity Practices in Infant Nutrition and Care, or mPINC, assesses maternity care practices and provides feedback to encourage hospitals to make improvements that better support breastfeeding. About every 2 years, CDC invites all hospitals across the country with at least one birth in the past year to complete the mPINC survey. CDC calculates a total mPINC score for every participating hospital to indicate its overall level of maternity care practices and policies that support optimal infant feeding. Responses are scored using an algorithm that denotes the evidence and best practices to promote optimal infant feeding within the maternity care setting. Possible scores range from 0 to 100, with higher scores indicating better maternity care practices and policies. Subscores further categorize maternity care practice domains and are scored using the same approach. These domains are immediate postpartum care, rooming in, feeding practices, feeding education and support, discharge support, and institutional management. I've compiled data from 2018, 2020, and 2022 to show mPINC scores over time for the total score, as well as the 6 domain scores. Since 2018, the total mPINC score has increased from 79 to 81, and we see higher scores across most domains. Consistently, the domain with the highest national score is feeding education and support, which covers items like identifying feeding cues and breastfeeding problems, while the lowest domains are typically rooming in and institutional management, which include items like rooming in safety protocols, the assessment of staff competencies, and written policies. In this map, state scores were calculated as the average of scores for all participating hospitals within that state. These were color-coded as shown in the key at the top, with darker blue indicating higher scores and lighter teal for lower scores. This map shows total mPINC scores for 2022. The national total score was 81, and the range of state scores varied from 72 to 93. We collect these data on maternity care practices for monitoring purposes, but we also want mPINC data to be used for action. These data can be used at a variety of levels, from the hospital to state and national levels. Every 2 years, we release national, regional, and state mPINC reports to provide an overall picture of maternity care supportive of breastfeeding in the US. Together, these reports can be used to provide context for jurisdictions. For example, our regional report shows state participation, total score, and domain scores by region. This type of report allows states to see how they are doing in relation to their neighbors. We also provide individualized reports to each hospital, showing their total and domain-specific scores. In hospital reports, we provide average scores among facilities of similar size, in the same region, and among all participating facilities for comparison. Participating hospitals receive their mPINC report roughly every 2 years, but how do they use it? First, hospitals often use mPINC as part of quality improvement initiatives. Hospitals use mPINC data to see how they align with baby-friendly standards. They use the mPINC questions to determine standards of care, and they will base their quality initiatives off their lowest scoring questions. Second, hospitals use their mPINC reports for benchmarking. They compare their own scores cycle after cycle to see where they can make improvements, and they also compare to other hospitals across their state and can use that as leverage for practice changes. Third, reports are used for staff motivation. Hospitals highlight key areas where they did well and post the report on bulletin boards for staff to see. Staff motivation also comes from those regional and national comparisons to validate and celebrate the work they're doing. Lastly, mPINC scores are used as part of staff education. Hospitals will use mPINC scores as a driver to provide more staff education in low-scoring areas. We also want to share some qualitative data on how jurisdictions use their mPINC reports. First, state reports allow partners to advocate for state policies based on where hospitals fall behind clinical standards. Second, benchmarking. State and regional reports allow states to compare their scores to others in their region or compare their own scores cycle to cycle. Lastly, we've heard that mPINC reports are used when applying for funding opportunities. And how is mPINC used by breastfeeding coordinators? mPINC reports allow breastfeeding coordinators to consult with hospitals to see where they can improve staff education and patient education. mPINC reports are also great for local outreach. Coordinators can share their state's mPINC scores with other groups specializing in breastfeeding, including WIC, Head Start, childcare providers, and coordinated care organizations. I'd like to take a step back and highlight a unique aspect of mPINC that you've probably gotten a sense for as I've been speaking. You may know CDC for putting out data known as surveillance. Surveillance is the ongoing, systematic collection of health-related data to inform public health practice. CDC uses mPINC to get a picture of maternity care practices supportive of optimal infant feeding across the country. But mPINC can be used for more than that, as hospitals take the mPINC survey, and then later when they receive their hospital report. mPINC raises awareness among hospitals of best practices and any gaps in their maternity care practices and policies. This feedback mechanism is pretty unique among other large surveillance systems, which typically passively collect data and don't necessarily report it back to participants. In contrast, mPINC provides an opportunity to learn and take action. As I've said, mPINC can function as both a surveillance tool and to inform interventions, especially at the hospital level. I've pulled some open text responses from hospitals who participated in the 2022 mPINC survey to demonstrate how hospitals use mPINC data. Respondents seem to appreciate the ability to see their scores improve over time, saying things like, "We've worked very hard to improve our scores and are very proud of our accomplishments." On the awareness raising and intervention side of things, respondents say, "It raised awareness of what we should be doing and measuring," as well as, "The questions provided insight into areas we can improve upon, as well as measure better." These comments suggest that hospitals use the mPINC survey as an opportunity to make improvements to their maternity care practices. In summary, whether your work is at the hospital, community, or governmental level, there are steps you can take to use these data for action to improve the health of infants and families. First, know your hospital or state mPINC scores and share them with key people in your organization. Use that information to identify both areas of success as well as areas for improvement to inform future work. Second, you can also encourage hospitals to participate in mPINC. The more participants, the more accurate a picture it provides of maternity care practices across the US. And lastly, look out for the mPINC 2024 survey, which is scheduled to launch in early 2024. You can join our mPINC listserv to receive periodic updates about the survey. If you would like to sign up for our listserv, please email mpinc@cdc.gov with your name and email address. Thank you, and I am pleased to pass the mic over to my colleague, Dr. Daurice Grossniklaus.
Thank you, Kristin, and hello, everyone. I will be giving an overview of our quality improvement efforts to support hospitals to provide evidence-based maternity care supportive of breastfeeding, the optimal form of nutrition for most infants. Evidence shows that hospitals play a critical role in helping families to start and practice breastfeeding and in connecting breastfeeding families to community resources. The Surgeon General's call to action to support breastfeeding was released in 2011, and it called for hospitals to do more to implement the 10 steps to successful breastfeeding. These 10 steps are a set of evidence-based maternity practices that, when implemented together, result in better breastfeeding outcomes. The 10 steps form the foundation of the UNICEF and the World Health Organization's Baby-Friendly Hospital Initiative, which recognizes those hospitals globally that implement the 10 steps and adhere to this high standard of maternity care. Baby-Friendly USA is the national authority, and in this role confers the Baby-Friendly designation to U.S. and territorial hospitals or facilities. Why is CDC's quality improvement work so important? In 2011, when we started this work, only 5% of U.S. infants were born in baby-friendly designated facilities. The majority of infants were born in facilities that were not practicing maternity care or infant feeding routines that fully supported breastfeeding women. This afternoon, I will describe our collaboratives, including 2 aimed at supporting hospitals to become baby-friendly designated, 2 aimed at building maternity staff capacity to support breastfeeding, and our newly funded project aimed at improving breastfeeding supportive maternity care. Best Fed Beginnings was our first collaborative focused on achieving designation. It was successful, and 76 of the 90 hospitals reached our goal. We estimate that an additional 250,000 infants born each year received optimal breastfeeding support. Empower Breastfeeding was our second collaborative focused on becoming designated. It was also successful, and 72 of the 93 hospitals reached the goal. We estimate that an additional 157,000 infants each year received optimal breastfeeding support. What did we learn? These projects had ambitious outcomes to be accomplished in a short amount of time, and we learned that with support, hospitals could achieve designation in a 3-year time period. Support included training and tailored technical assistance provided by QI and/or breastfeeding experts and coaches, using QI methods such as plan, do, study, act cycles, and small tests of change to make sure that practice changes that were being implemented actually resulted in improvements in maternity care. We also learned the importance and value of having well-trained maternity staff at the bedside to help breastfeeding families 24/7. And the challenges hospitals faced in providing this training to their staff. We use the lessons learned to inform our next funding opportunities and focus on helping hospitals overcome the training-related barriers. Empower Training was a 2-year collaborative that focused on training maternity staff in the 5 hours of breastfeeding skills. This project was successful in meeting the goal, and 81 of the 85 participating hospitals reached the training goal. This translated to more than 3,600 staff receiving over 18,000 hours of training. Empower Best Practices is our current collaborative that began in 2020 and runs through September of 2024. The goal is to train staff in those hands-on breastfeeding skills. To better address disparities in breastfeeding rates, the Empower team developed training related to health equity. This training is designed to help maternity staff navigate their own implicit biases and provide culturally competent care. The Empower training is delivered on an e-learning platform, and it is organized in modules with a module for each of the 10 steps and a module dedicated to communication skills. Each module includes learning objectives and performance indicators, case studies, self-reflection activities, knowledge checks, and relevant resources and job aids. This is an image of Lorraine, who serves as a virtual trainer and mentor. This is an example of one of the case studies. This particular case study focuses on building the skills needed to communicate effectively across cultures. There are case studies for each of the 10 steps, and each case study includes brief background information to provide some context, a scenario that staff would likely encounter in their day-to-day work, and questions to answer with the help of Lorraine, the virtual trainer. A unique aspect of this collaborative is that an equity community of practice grew organically from the work. Staff identified a need for help with how to integrate equity principles into maternity care. Activities include regular webinars to learn from experts and peers, to share challenges and solutions across hospitals, and to share equity-related resources. The e-learning platform provides a forum for ongoing discussion. I wanted to share successes that we have seen in our current collaborative, Empower Best Practices. The first is a quote from a nurse and international board-certified lactation consultant at the University of North Carolina Hospitals. This hospital was the first in the nation to be successfully assessed on the new Baby-Friendly USA training criteria. Another hospital, Advent Health Fish Memorial, was able to create a report summarizing their participation and the impact on the families they served. They shared it with their hospital leadership and other partners to show the value of their work. These are 2 examples of the importance of our quality improvement work and how these efforts impact infants and families. So what has been accomplished? We have added the progress made since 2011, which is indicated by the orange line. The percent of births occurring in designated hospitals rose from 5% in 2011 to almost 29% in 2021. Our work with the Best Fed Beginnings and Empower Breastfeeding hospitals contributed in part to this increase. However, this graph also reflects the contributions of other organizations and facilities and the dedication and hard work of many people. For example, it reflects those Best Fed Beginnings and Empower hospitals that have successfully maintained their designations and or achieved redesignation, and those in our training collaboratives that have gone beyond the expectations to achieve designation. We have contributed in part to more than 1 million infants each year receiving maternity care that supports breastfeeding and optimal infant nutrition. As a nation, we have made remarkable progress, but there's still work to be done. To continue this work, we awarded funding to the Center for Health Equity, Education, and Research at Boston Medical Center. They will begin work in September of 2023 and will enroll 100 hospitals to take part in a collaborative. This collaborative is designed to increase the use of culturally competent approaches to improve breastfeeding supportive maternity care. CDC is committed to continuing our work to support hospitals and to ensure equitable access so that all individuals and families receive optimal breastfeeding support. This work has a profound impact on the health of families across our nation. Thank you for the opportunity to share our work with you. I'll now turn it over to Harumi. Thank you again.
Hi, everyone. And thank you, Daurice. And thanks to the DNPAO for having us here in the last day of this very important month and very important week. So we just heard from CDC a lot of what's happening with breastfeeding in the hospital and how hospitals have improved many of the 10 steps, which then result in this great increase of the breastfeeding initiation rates. It's awesome. We heard from Lieutenant Kristin that most births happen in the hospital. And as we like to say here in NACCHO, breastfeeding usually starts in the hospital, but most of the breastfeeding journey actually takes place in the community. Hopefully this journey lasts for at least the next 2 years after the hospital discharge, right? But if the community infrastructure does not enable breastfeeding, we won't see breastfeeding duration and exclusivity rates increase so much, like we saw with the initiation rates. So how do we build the same supportive environment that we have in baby-friendly hospitals also in the community? So this is mostly what we do here at NACCHO, and I'll be sharing some of the highlights of the past 5 years of our program that we have done with support from the DNPAO. It's like steps 3 and 10 of the 10 steps and beyond, way beyond the hospital walls into the community. Well, I'll start just talking a little bit about us. NACCHO's mission is to improve the health of all communities. We have several different public health programs here to help advance our mission. Our program is within the maternal, child, and adolescent health team. NACCHO is a national organization, but with a local community reach. Our team has been working with CDC for nearly 10 years, but NACCHO as an organization has partnered with CDC for the past 50 years in different programs. We are in the final year of the 6-year project. We operate with the mission to advance continuity of care to enable breastfeeding to be the easy default choice in all communities, especially those communities where breastfeeding is not a feasible option for many families. So you're going to see our goals in the next slide that are to increase the operational capacity of local public health systems to advance continuity of care. It is also to identify and amplify local successes and best practices to increase specifically the breastfeeding duration and exclusivity rates, and also strengthen partnerships to advance the first 1,000 days nutrition. So we do that through these activities. We fund local organizations and their partners to advance continuity of care in their communities. In this project period, we funded about 35 communities, and we will be funding some more soon. We also provide training and technical assistance to communities. We have provided over 400 hours of technical assistance to grantees and also the CDC REACH recipients. Another activity is fostering partnerships at the local, state, and national level. For example, at national level, we convened the Breastfeeding Public Health Partners in 2014, which is a group of about 10 national organizations, and we're still very active. And finally, we've developed the Continuity of Care Blueprint that just turned 2 years old last week. So the blueprint is a systems approach for communities to consistently provide this continuous, high-quality lactation support and supportive environments for families. It was designed to build a safety net for families before and after the hospital delivery throughout the first 1,000 days of life. So the centerpiece of the blueprint are the 43 strategies to improve care coordination and communication among providers, and the establishment of proactive supportive policies, systems, and environments throughout the community. So since the launch, there were over 2,000 downloads from every state in the country, and surprisingly, we also had downloads from other 20 different countries. Also in this map, you see the red stars representing grantee communities that implemented the blueprint. Grantees were a mix of local health departments, community-based organizations, FQHCs, breastfeeding coalitions, and some hospital systems. So here are some of the trainings that we did for the past 2 years. We have an accredited continuity of care series, and each webinar showcased speakers from communities that were successful implementing these strategies. We had great participation, and you can still watch the recording and claim most of these continuing education credits. And on the next slide, you're going to see a bit of history of the grants that we put together through the past 5 years. The last 3 cycles were related to the blueprint implementations, and also a note there that from 2018 to 2023, we also worked with rich recipients implementing continuity of care in their communities. Finally, you're going to be able to see here the outcomes from the past, well, the preliminary outcomes from this past 2 years of blueprint implementation. Collectively, grantees increase capacity and diversify the lactation workforce in their communities. They have also conducted community lactation-specific assessments to understand gaps in continuity of care in their communities, and then to focus efforts where they need the most. They have also improved breastfeeding policies, systems, and environments in many settings in the community. So they increased the availability of supportive environments throughout the spaces where families live, work, play, and raise kids. And finally, the heart of our project is to foster local partnerships, because this is a must to advance continuity of care, since no one can do continuity of care alone. So there were lots of partnerships formed or strengthened, especially those collaborations with agencies that address social determinants of health. So they provide care for the family holistically, and it's not just solely focused on latching baby to breast. Also, a great success for many grantees is that they improved their referral systems and strengthened their handoff policies and procedures. Finally, grantees also focused on building authentic relationships with family through family-centered care, father engagement projects. So there's a lot to describe in one slide. I hope you go check out their stories in the Continuity of Care website. And for the next step, you see that we just launched our request for application for the 3rd cohort to implement the blueprint. And this time we're also looking for applicants who propose strategies to also improve child nutrition security. So check out our RFA in the same website, and the link is on the chat box. And next, thank you so much, DNPAO, for having NACCHO, and I'll turn it over to our amazing grantees in Jefferson County. Lucy and Paulina were part of our last grant project, and we had the chance to visit their community last month. We're so amazed by all the work they do to build continuity of care for the Latina community, and I'm sure you all are going to be just as inspired. Gracias and bienvenida, Lucy and Paulina.
Hello, everybody. Thank you so much for the invitation to join today. We are delighted to share about how we're needing networks of care and support for our families after the hospital discharge in community. So we're in Colorado, and this is how people think of Colorado. It is gorgeous. Just like our families and our communities, this is where we live, where we learn, where we grow, we play, where we pray. For us doing this work, though, it's important to have another perspective, because not everybody gets to play in these mountains, no matter how close they are to them. This is a map of the Child Opportunity Index, which shows disparities in opportunities for children in the Denver metro area. The lighter colors show where our communities or children have less opportunities, and the darker colors show abundance of opportunities for them. This is where we work. We work in the lighter areas, the lighter blue areas. This is where our immigrant communities live, and also the historical geographical locations of redlining. This grant has allowed us to dream, to start thinking about how we rebuild connections so those opportunities become available for everybody in our communities. We have been able to imagine and build a community where groups with different knowledge, information, and power start connecting. In our study, we did a qualitative study of the experiences of families after discharge. We heard that when families leave the hospital, even baby-friendly hospitals, they have no connections of support in their communities. They experience profound isolation. So our job has been to create those networks to weave neighbors in neighborhoods and networks, so everybody could have someone in their closest contact that can give them information and support related to lactation, breastfeeding, and nutrition, infant nutrition. We have not done this on our own. We're also weaving networks between organizations. JCPH supported us through funding mechanisms and helping us to align our work with the health priorities of the county. Then Edgewater Collective helped us to build our structure, organizational structure, and we, Cuenta Conmigo, we were able to bring local knowledge and experience to make this happen. We make connections. We are those touch points between the resources, the organizations, and our families. In the next week, we are celebrating at national level the Latino Lactation Week, and we'll be celebrating across the country. And in a couple of weeks, our team will be traveling to Arkansas to also share our experiences, to train on clinical lactation at community level, so other communities can also start creating their own networks of support at local level. Thank you so much. Lucy, your turn.
Gracias, Paulina. ¿Cómo lo hacemos? Aumentando la capacidad de nuestra comunidad al hablar en el lenguaje de su corazón. Somos sensiblemente culturales, la comunidad se siente incluida y eso las motiva a seguir adelante y poner en práctica lo aprendido en y para las familias. Próxima, por favor. Esto es posible porque proveemos capacitaciones de preparación comunitaria, alimentación infantil segura en emergencias, lactancia clínica, certificaciones de amigos de la lactancia a las proveedoras de cuidado infantil, y tenemos sesiones de estudio mensuales con participantes locales y de varios estados, con casos reales donde estamos aprendiendo unas de otras. Próxima, por favor. Estamos aumentando la presencia de las familias con grupos presenciales, virtuales, con cafecitos, donde estamos escuchando, hablando y apoyando las necesidades de lactancia, nutrición, salud o cualquier otra necesidad que tengan las familias. En alianza con otras entidades y todos en conjunto, con un mismo objetivo, estamos trabajando reflejando los intereses de las familias con una amplia visión desde nuestra experiencia y conexión. Próxima, por favor. Sabemos que el tratar cultural y directamente con las familias radica en ese contacto personal. Es una manera efectiva de crear confianza al tener visitas uno a uno, presenciales, virtuales o por teléfono. Escuchamos activamente al quitar las barreras del lenguaje. Las familias se sienten más comprendidas, acompañadas y creamos lazos de confianza muy significativos. Realizamos entrevistas y expandemos nuestro rol al saber que la transición del hospital a la casa es agobiante y a veces hasta traumante. Ser mamá es un trabajo muy agotador porque no sabemos qué hacer al momento de estar a solas con el bebé. Quizá no hay quien pueda apoyar sus necesidades inmediatas. Nosotras les dejamos saber que estamos ahí para acompañarlas en esos momentos difíciles desde la perspectiva cultural, en el mismo lenguaje, con el mismo sentimiento y con esa profunda mirada desde nuestra experiencia y comprensión. Próxima, por favor. Sabemos que está funcionando porque constantemente estamos escuchando y reflexionando lo que quieren las familias. Creamos esa red de conexión con otras entidades para apoyar las necesidades de lactancia, nutrición, salud y bienestar de nuestras familias en la comunidad. Somos navegadoras y respondemos a sus intereses. Apoyamos con recursos disponibles, les enseñamos las habilidades de cómo pueden aprender a hacerlo. Con esto estamos empoderando a las familias, desarrollando la confianza de que pueden hacerlo por sí mismos. En los pequeños momentos de lactancia, escuchamos culturalmente desde su experiencia en el hospital, cómo está funcionando la lactancia, su salud y bienestar ahora mismo, hasta cuáles son sus expectativas futuras. Seguimos desarrollando confianza, estamos conectadas y respondemos a las familias en la comunidad. Siguiente, por favor. Aquí tenemos nuestra información por si desean contactarnos y muchas gracias por la oportunidad y ahora se lo paso a Janelle.
Gracias, Lucy. Thank you to our panelists for our wonderful presentation today. Before we move on to the questions and answers, want to remind folks to stay connected with us here at CDC. We have both a Twitter and a Facebook account. If you're not following us, go ahead and follow us. And wanted to also share, we have some great resources, including those related to breastfeeding in our State and Community Health Media Center, and also great data on our data trends and maps. So I'd invite all of my panelists to turn their cameras on, and we will do some Q&A. First question is for you, Daurice. Are the training materials being used in the Empower projects publicly available?
Yes, the training materials that were used in the first Empower training project or collaborative are publicly available, and I believe that we dropped the email or the URL in the webinar chat box. They're available on the UNC Chapel Hill website, and we are currently working with our partners to make available, after the conclusion of our current project, Empower Best Practices, the training materials. Does that answer the question?
It does. Thank you. The next question is for Harumi. Have you identified some commonalities among grantees that were very successful?
Thanks, Janelle. Yeah, we're still analyzing all the data, but I think one of them that stands out is the grantees, like Jefferson County here, that they already had this partnerships in place. So they weren't trying to build trust and collaborate during a 9-month project. So the ones that were already had those relationships in place were more successful. I think another factor that comes to mind now is the ones that really worked with the community, co-created with the community, got community input, or even onboarded community member as that community expert advisor. So they really created services that really fit the needs of the community they're serving. I think those two that comes to mind now.
Thank you. Kristin, the next question is for you. It's about the mPINC data and how can the public access mPINC data, and is individual hospital data available?
Yeah, thanks for that question. So hospitals will receive their individual reports, which are confidential and not publicly available. They'll be sent out to the hospitals at the conclusion of our survey. We do have national, regional, and state reports that are publicly available on our website. And for researchers looking to use mPINC data to answer research questions, or state health departments who are looking to use mPINC data for the development of public health programs, we have data available, and those folks can email mpinc@cdc.gov to learn more and receive a data request form.
Thank you. And then Paulina and Lucy, the next question is for you. How can communities support each other in breastfeeding decisions?
That's a beautiful question. I actually would love to know as well. What we know is that people are asking for information. People are asking to be able to make decisions. They want to have a trusted partner that can give them the information that they need, not just about, oh, it's so good that you're breastfeeding, just go ahead and do it, but actually how do they solve the day-to-day challenges to make that happen? So I think that the supporting each other with decisions has to do with what are the possibilities, what are the visions that people and community are building together in order to fulfill their goals in this journey of breastfeeding.
And then there's a follow-up. Folks are interested in what meeting you'll be at in Arkansas.
We're teaching one of our clinical curriculums in Arkansas, in Springfield, in the University of Arkansas. It's going to be a week-long training with an amazing group. We met them yesterday. Actually, it's all going to be in Spanish and very, very culturally based. We tend to discuss those challenges that are specific to our communities, as well as the celebrations that we have. There's so many strengths in our community that help us build up solutions in ways that are way easier to see and explore and advance when we're there with community. Thank you for those questions.
Yeah, thank you. And keep questions coming in. Harumi, there's a question for you. In your work, how do you see hospitals supporting community programs? And do you have any stories of hospitals implementing the blueprint?
Yes, we definitely have. I would say about 1/3 maybe of our grantees are hospital systems. I can give some examples of the past year or 2 years. We had University of Chicago Medical Center. So I think they really provided that constant care because they're a university hospital. So they actually hired a community IBCLC to be in contact from pregnancy through postpartum with their patients instead of them seeing different providers all the time. The other one is the Cincinnati Children's Hospital. They are a group of so much experienced physicians and community. They do great community clinic partnerships. So they really worked on improving their warm handoffs from the hospital to the community. And also they focused on really increasing the supportive environments in the community. So I think they have a quality improvement going on with a bunch of their early care and education settings. And finally, the other one that we have was the MedStar Hospital, that it was the current grantee in Baltimore. And they did a fascinating partnership with City of Refugee, that is a resilience center for the Baltimore community. And they provide food, fresh foods, career advancement opportunities, and diaper bank. So they co-located their lactation support in this diaper bank. So it's really, really rich and holistic, and the way they are providing care. So I think those three come to mind, but check our stories in the Blueprint website that you're going to see way more ways that hospitals have been supporting communities.
Thank you. Lucy, the next question is for you. Do you have any lessons from the COVID time period in best connecting with communities?
Sí, creo que COVID nos trajo una gran lección a todos, ya que la comunidad con la que yo convivo, que es la comunidad hispana, realmente estábamos muy desatendidos. Había muchos recursos en la comunidad a los cuales no teníamos acceso, y el COVID vino a abrir las puertas para que las personas realmente se estén dando cuenta de estos programas que pueden ser posibles, que están al alcance de la mano, pero más que todo, la comunidad lo que necesita es ese contacto directo, de decirlo uno a uno, y creo que esa es la lección que nos ha traído COVID. Gracias.
Thank you. Kristin, the next question is for you, and it's about when will the next mPINC survey take place?
So we are planning to launch the 2024 mPINC survey starting in early January. So folks can stay up to date on the survey's progress by subscribing to our listserv and checking the blue update boxes that we put on the top of our mPINC website. And maybe someone can drop the link to the mPINC website in the chat as I'm speaking. But we'll be periodically sending updates through both our listserv and posting those on the website. And I will say it takes a little bit of time to reach out to all hospitals across all the states and territories. So hospitals in your area may not be contacted until closer to February. But if you have any questions about the survey or would like to request a previous hospital report or mPINC data, like I said before, you can reach out to mpinc@cdc.gov.
Thank you. Daurice, If hospitals in my state are interested in taking part in the newest initiative, how would they learn more?
Thanks for the question. I think the guidance would be to check out the CHEER website. And I think we have that in the chat, and also you can send an email to CHEER at their Gmail account, which is also in the chat and on their homepage. Their period of performance begins at the end of September, so they may not really start recruiting hospitals until a little bit later than that, because they have some planning to do and that sort of thing. But begin watching for updates on their website around October, please. Thanks.
And Paulina, our last question will go to you. What do you see as some of the biggest opportunities and challenges for organizations like yours to promote breastfeeding?
The opportunities is that we have communities who are really accepting and caring and very concerned about the health of our families and children. So I think that we have the ground. Has been cultivated, right? We are there ready. I am not finding an argument. I don't have to argue about how beneficial this is, right? People are ready to jump in and start doing it. There may be some cultural barriers sometimes because there's a misalignment of how we're presenting the context, how we're presenting our values, but there's so much work that we can do, creating some congruential, like equivalent meaning. I will say that we can bring together these goals. Now, in terms of challenges, I think that the work, for example, the work that we do is there's no funding for this kind of thing. We are piecing together things. We are like, thanks to NACCHO, this really helped us set up a structure that then will allow us to launch this into the next steps. But we have families, we work with families, actually more than Spanish. We have also seen Vietnamese families, and they come to us because we have an understanding of immigration experience, of refugee experience, that other communities, or I would say the more dominant cultures, do not have. So some of the challenges is that this work is extremely important. I think that we are at that moment, at that link between everything that our institutions are trying to accomplish and what is a real community experience. We're right there in the middle. And unless we get funded, unless we get recognition and support for lactation counselors, for navigators in the community, because we do it all, right? We're not just lactation counselors. We have to do navigation on housing, on food access, on education. Everything comes, and we will take it and run with it because that's what our families need. So a recognition that this role is essential to build this infrastructure needs to happen. And I think that's the biggest challenge that we're facing right now.
Thank you. Well, if everyone can please join me in a virtual applause for our outstanding panel today. We're so glad that we were able to spend this last day of Breastfeeding Month with you all, and really appreciate all of the great content and resources that were shared today. This seminar, as with our others, will be posted on the DNPAO website. And thank you all for joining us.